Welcome back to MLT 120. Today we're going to discuss what polycythemia is and some different classifications for polycythemia. So what is polycythemia? It is a condition where we have too many blood cells. So it is the exact opposite of anemia, where we have too few blood cells. Polycythemia can happen for different reasons depending on the condition or the disease that's going on in a patient. We can have just erythrocytosis going on in a patient, which is just increased red blood cells, or we can have an increase in the myeloid cells. That would be all the cells from the myeloid side. Remember, we started out with the hemopoietic stem cell, and it split off into the myeloid side and the lymphoid side. So all the cells on the lymphoid side could be increased. That would include the red blood cells and the white blood cells, which are also referred to as the granulocytes, and also the monocytes and the platelets could be increased. So it just really depends on the condition and what's going on with the patient. What type of polycythemia they have, whether it's just increase of red cells or if they have an increase of that whole myeloid line. And we also have this term here on the slide, panamylosis. This is associated with a leukemia. This is associated with acute myeloid leukemia, or AML, and this is associated with increased immature blood cells. We have two different classifications for polycythemia. One is relative and the next is absolute, and we're going to talk about each on the next few slides. First up is relative polycythemia. Relative polycythemia is caused by a dehydration of fluids. So we have an increased blood cell count as a result of loss of fluid or dehydration. The second classification is absolute polycythemia. Absolute polycythemia is when the bone marrow is just producing too many cells. The reason for overproduction of cells can be further classified as either primary or secondary based on the cause of overproduction. Okay, primary, the bone marrow is producing too many cells because of a myeloproliferative or malignant condition called PV, or polycythemia vera. In the secondary absolute polycythemia, there's an overproduction of cells secondary to another cause outside of the bone marrow. Remember, our red marrow is our blood cell producing marrow, or our active marrow, and our yellow is our inactive or fatty marrow. So on the next couple of slides, we're going to talk about polycythemia vera a little bit more in detail. And again, this is a chronic myeloproliferative disorder. It's acquired and it's malignant. So when you think malignant, think cancer. And it's characterized by proliferation of hemopoietic cells and fibroblasts in the bone marrow. So this is happening in the bone marrow, and the bone marrow is just overproducing cells. So it's overproducing red cells, white cells, and platelets. In polycythemia vera, again, we're going to have an increased production by our bone marrow of all our cell lines, and we're going to have an increase to the point of 2 to 3-fold increase in blood volume, yet the plasma volume remains the same. So the cells increase, but the plasma remains the same. Thus, we see an increased viscosity of the blood. And viscosity is referring to the thickness of the blood. We have so many blood cells being produced that the blood thickens. The median age is about 60 years of age for patients with polycythemia vera, and there's a slight predominance in men to have PV. Polycythemia vera patients usually have an increased skin color. They also have an increased BP, which is blood pressure, and they also suffer from splenomegaly, which is an enlarged spleen. They just have so many more red blood cells to deal with. Remember, the spleen is the organ that takes out red blood cells in the red blood cell degradation process. Also, there's an increased red blood cell production, even though the patients usually have low to normal erythropoietin or EPO levels. So why would this be? Why would a PV patient have low erythropoietin levels? This is because patients already have too many red blood cells. So thus the negative feedback will decrease the erythropoietin levels because it's not needed. They don't need to produce more red blood cells. So because the body already has too many red blood cells. The whole point of erythropoietin is to kick off the production of red blood cells. Well, the PV patients already have too many, so they're not going to have an increase of erythropoietin saying, oh, make more red blood cells, because they already have too many. And these patients usually suffer from a chromosomal abnormality called the JAK2 mutation. And the treatment for that is usually, or the treatment option for PV or polycythemia vera patients is usually therapeutic phlebotomy on regular intervals. So they'll go in for just blood draws to help get rid of some of those blood cells. And this can extend the patient's life for years. Also, there's some therapeutic or therapies out there, some myelosuppressive therapies, and that would be drugs that help suppress bone marrow, and also targeted molecular therapies in the form of medications. Patients usually die from associated complications of increased viscosity of the blood, or the blood is too thick. If you look here on the diagram on the right hand side of our screen, we have our normal patient versus our polycythemia vera patient. If you look here, our normal patient has the negative feedback regulation in place versus the polycythemia vera patient does not. And also the polycythemia vera patient has that JAK2 mutation. So this is going to allow for an unregulated red blood cell production. So they're going to overproduce their blood cells, where this negative feedback system is going to help regulate that blood cell production, and not too many red blood cells are not going to be produced. Okay, on the last few slides we've been talking about primary absolute polycythemia and talking about polycythemia vera, but now we need to cover absolute polycythemia secondary, and this is where there's an overproduction of cells secondary to a condition outside of the bone marrow. So it can be caused by an increased level of erythropoietin. It can be caused by a condition of hypoxia, which is decreased oxygen. Secondary can also happen when there's normal O2 levels, but there's an increase in erythropoietin because of things like tumors in the liver, renal system, or the brain. So on this last slide, let's do a little comparison in between our two different types of absolute polycythemia. So we can have primary and we can have secondary. And our primary are our patients with polycythemia vera or PV. And they are people that have a problem with bone marrow. So they have an increased production in the BM, which is that's referring to bone marrow in this case. They have a hypocellularity, which includes all cell lines. That includes the red blood cells, the granulocytes, which we're talking about, our white blood cells, and our platelets. So all the cells in the myeloid line that come from the bone marrow. And these patients are positive for that JAK2 mutation in most cases, about 95% of cases. And the erythropoietin levels are usually low to normal in primary. Over here in secondary, the bone marrow hypocellularity is only in the erythroid line. So these patients are usually negative for that JAK2 mutation, and the erythropoietin levels are usually increased. Also remember in secondary, the overproduction of cells is secondary to another cause outside of the bone marrow. So it's affecting the bone marrow, but the cause is outside of the bone marrow. That concludes our lecture on polycythemia. If you have any questions, please don't hesitate to reach out, and I'll see you over in the next lecture.